All right, good afternoon, everybody. I'm excited about this session. We're going to try something new at the FMDSA conference. We're calling this session the FMD Clinical Research Roundup. And basically what we decided to do as a scientific advisory board is we recognize that beyond the registries and our FMD registry, some of our registry investigators at their own site are doing novel work in the FMD space and wanted to give a forum to present some of this work in progress. I think you'll also notice this is going to be a really fun session because we have some fresh, young, and new faces in the FMD research world, folks who are presenting for the first time at the FMDSA meeting, and we hope take a future interest in FMD-related research. So we are going to have 5 presentations. Each is going to be about 5 to 7 minutes. And then we're going to have a little brief commentary and panel discussion after each one with myself, Dr. Olin, Dr. Freilich, Dr. Ganesh, and Dr. Kim. We'll have maybe each abstract will have a couple of comments, and then hopefully at the end of the day we'll have time for the audience to have some questions. I will say these are all like fresh research presentations that have been given at national meetings. They are not yet published in a peer-reviewed format. So this is very early emerging research. Okay, so with that, those ground rules. What we're going to do, we're going to have each presenter share their own slides. So Dr. Mustapha, you have your slides available to present? Okay, so our first presenter, and actually when you present, I'm going to have you also tell the audience, we have actually over 400 people on today, don't want to make you nervous, but tell the audience where you are in your training with FMD. But our first presenter is Dr. Aishat Mustapha, who is from Emory University. She's going to present on duplex criteria for hemodynamically significant renal artery stenosis in FMD, and her mentor is Dr. Wells, and I was also involved in her project. Welcome, Dr. Mustapha.
Thank you. Is everyone able to see my screen?
We were, and then it went away. I think you just have to reshare. There you go. And then just perfect. Yes.
Hi, everyone. I'm Aisha Mustapha, and I'm currently a cardiovascular disease fellow at Emory. I did my training in vascular medicine with a one-year vascular medicine fellowship at Emory prior to starting my cardiology fellowship. And I'm currently in my second year of training of cardiology fellowship. And I'm excited to speak to you all today about our investigation into duplex criteria for hemodynamically significant renal artery stenosis in multifocal fibromuscular dysplasia. So I'm sure that all of you have heard today that fibromuscular dysplasia, or FMD, is a non-atherosclerotic, non-inflammatory disease that predominantly affects medium-sized arteries, such as the renal arteries, typically in the mid to distal portion, causing areas of narrowing or stenosis, widening or aneurysms, dissections, or tortuosity. It is the second most common cause of renal artery stenosis behind atherosclerosis, which is essentially cholesterol plaque buildup in the renal arteries, causing narrowing or stenosis, typically in the proximal portion of the artery. FMD can commonly be seen as these alternating areas of narrowing and widening, which we classically call the string of bead appearance. And you can sort of see that here actually in this picture. And what we know is that the gold standard for assessing renal artery stenosis severity is invasive angiography, which allows us to directly visualize the arteries and use tools called the pressure wire to measure the pressure gradient across a narrowing or stenosis. We also have duplex ultrasound, which is a non-invasive imaging modality that's commonly used to assess renal artery stenosis caused by atherosclerosis and fibromuscular dysplasia, amongst other pathology. And as you can see here in the picture on my right, this is a renal duplex ultrasound from an FMD patient. And this imaging modality is great because it provides parameters such as peak systolic velocity and diastolic velocity and a calculated renal to aortic ratio, which allows us to really extrapolate about the characteristics of a narrowing or lesion. For example, renal artery affected by FMD may be tortuous, leading to areas of turbulence or disturbed blood flow, which we see here on color Doppler as aliasing, and also lead to elevated velocities, which we can see with which we can measure with ultrasound. We also know that there are no validated duplex ultrasound criteria that we can correlate with hemodynamic stenosis by angiography for renal artery stenosis in FMD. And we have these criteria actually for renal artery stenosis caused by arteriosclerosis or plaque buildup. So this was the goal of our study. Our study is a retrospective analysis of patients with multifocal muscular dysplasia diagnosed by CT, A, or MRA, which is essentially MRI, between the years of 2015 and 2023 at Emory University Hospitals and University Hospitals in Cleveland. The patients in our study had duplex ultrasound followed by renal angiography within a 6-month period. Their angiography included hemodynamic assessment with a pressure wire, which I mentioned before, which is able to allow us to measure the distal to proximal ratio, which we call PD to PA ratio. And what we decided, as mentioned earlier, is that hemodynamically significant renal artery FMD would be defined as a PD to PA ratio less than 0.9 at the time of angiography. We also had duplex ultrasound information performed by expert techs at appropriately accredited labs, and we were able to measure, or their studies included measurement of Doppler at multiple locations within the affected renal arteries, and so we had information about their peak systolic velocity and diastolic velocity and renal to aortic ratio. We also excluded patients from our study who had previously undergone renal artery angioplasty. Here are the baseline characteristics of our 29 patients and 41 renal arteries included in our study. And so what this means is that different patients had, some patients had more than one renal artery affected by FMD. And what we see here is that the average age of the patients included in our study is about 54. 95% of patients are female, which we know is sort of in line with FMD. 100% of our patients were diagnosed with hypertension with a mean systolic blood pressure of about 143 millimeter mercury. And lastly, we see here the average PD to PA ratio of the renal arteries included in our study was about 0.97. So here are our results. On the left side is a receiver operating characteristic curve showing the sensitivity and specificity of various maximum peak systolic velocities. And on the right side is a figure showing the correlation of peak systolic velocity and PD to PA ratio. So what we see here and what these figures are showing us is that there is a moderately inverse correlation between peak systolic velocity and PD to PA ratio with an R value of negative 0.48. And more specifically, that a peak systolic velocity greater than 300.6 centimeter per second was correlated with a PD to PA ratio less than 0.9, which is significant, with a sensitivity of 93.8% and a specificity of 57.1%. And so in conclusion, this is really, I think, the only study that I know of so far that's really tried to correlate duplex ultrasound criteria for renal artery FMD with hemodynamic parameters by angiography. And what our study shows is that a peak systolic velocity by duplex ultrasound greater than approximately 300 centimeter per second suggests a hemodynamic significant stenosis in renal artery FMD by angiography with a PD to PA ratio less than 0.9 with an acceptable accuracy. Our study is not perfect. It's a retrospective analysis with a small sample size, which limits its generalizability, and it does not apply to renal arteries that have undergone prior percutaneous angioplasty, which is essentially ballooning of arteries that are narrowed, or stenting procedures. And so what do patients need to know? What can patients take away from this? Is that really defining duplex ultrasound criteria for identifying hemodynamically significant renal artery FMD, I think is valuable for patients, for physicians, specifically in patients with renal artery FMD who have uncontrolled hypertension. And having such criteria can help physicians really, I think, select patients appropriately and select the patients that deserve further assessment with a more invasive procedure, such as a catheter-based angiography to confirm that diagnosis, and also determine which patients need referral for therapeutic interventions, such as renal angioplasty or ballooning of the artery. And in terms of next steps, we need further validation of this criteria with larger studies, larger patient size, more renal arteries to support the development of new duplex diagnostic criteria for identifying patients who have hemodynamically significant renal artery stenosis as a result of fibromuscular dysplasia. Thank you.
Terrific job, Dr. Mustapha. Congratulations. I'm going to have Dr. Olin and Dr. Kim on this one give some quick perspectives and commentary for a few minutes. Jeff.
Yeah, so that's a great study. Congratulations. As you noted, the sample size is very small, and more importantly, the number of individuals with a hemodynamically significant stenosis was very small. So when you state that there is, with a peak systolic velocity above 300, that is an indicator that there may be a hemodynamically significant stenosis. If I recall from the figure, there were very few people who actually did have a hemodynamically significant stenosis, but a lot more had a peak systolic velocity of over 300. So I think you quoted a specificity of 65%. I mean, that's pretty low. And I think there will need to be further work done to really work this out, but it's a great start.
Esther.
First, I just want to congratulate you, Dr. Mustapha. It's hard doing research like this, especially between two institutions, and getting all of that data. And research probably takes a lot longer than it needs to because the lawyers get involved. So I just congratulate you for your perseverance because I know that took a long time. I have similar comments to Dr. Olin because I know in clinical practice, I follow the renal arteries pretty closely with ultrasound. And I have several patients who have velocities well into the 300s who I have not sent for angiography. And so we have to think about the fact that all patients in your study actually went to the lab because there was suspicion that there was a stenosis in the renal arteries. So it wasn't that everybody had an angiogram and then you looked to see what the cutoff was. There was definitely a referral bias into the lab. But again, you know, the data is what the data is. And it's something that we can learn from, but probably not going to be the definitive study that tells us the criteria for FMD when we need to take people to the lab. But I guess from a clinical perspective, if I saw someone and their blood pressure was like maybe a little hard to control and their velocities were over 300, now I'm really going to think twice. Maybe I need to consider taking them to the lab.
Thank you, Esther. Thank you, Jeff. And Dr. Mustapha, congratulations. Thank you very much for presenting today. Up next, we have Karen G. Karen, are you here?
Yes, I am on.
There you are. Hey, Karen. Welcome. Karen, as you start your presentation, you're going to tell us where you are in your career trajectory. Karen is here at University Hospitals Case Western, and she's going to present prevalence of aortic pathology among patients with multifocal FMD.
Perfect. Okay, can everyone see my screen?
It's perfect.
Great. Okay, so like Dr. Gornik said, my name's Karen G. I am a second-year medical student, actually starting my third year this coming Monday, which is really exciting. But at Case Western Reserve University, I worked on this particular product under the guidance of my incredible mentor, Dr. Gornik. And today I will be sharing our findings on aortic involvement among patients with multifocal fibromuscular dysplasia. So FMD, as all of you already know, is a condition that affects your arteries, most commonly the medium-sized arteries. So you're thinking about the renal arteries that supply your kidneys, and then your carotid and your neck that bring blood up to the head. And it classically presents with that multifocal or focal stenotic lesion, so the beating, aneurysms, dissections, and tortuosity. While there have been previous case reports as well as registry studies noting aortic involvement, the true prevalence as well as the full spectrum of aortic pathology in FMD was still incompletely characterized. So our study set out to address that gap. With that in mind, we conducted a single center retrospective chart review in which we review the medical records of adult patients who had a confirmed diagnosis of only multifocal FMD and were seen at our institution's FMD and arterial dissection program between the dates of January 2019 and then July of 2024. To be included in our study, patients also needed to have had complete cross-sectional imaging of the entire aorta, from the aortic root in the chest down to the iliac bifurcation near the pelvis. And then in addition to collecting data on demographics, medical history, and family history, we specifically assessed for aortic pathology. We defined these aortic pathologies to include ectasia, aneurysms, acute aortic syndromes, stenotic lesions, and congenital anomalies. Aneurysms were defined using the standard diameter cutoff, so greater than or equal to 4 for the thoracic region and greater than or equal to 3 for the abdominal region. And ectasias were defined as enlargements that weren't large enough to be called aneurysms, but still large enough to warrant being watched. Figure 1 here shows the screening process. As you can see, we initially identified 478 patients from the registry, and then there were 2 rounds of screening, first based off of FMD type, in which we picked out the patients with only multifocal FMD, and then the second round based off of imaging obtained. And then after screening, a total of 360 patients with multifocal FMD had met both those inclusion criteria. Of these 360 patients, 36 of them, so that's 10%, exhibited definite aortic pathology. The most common findings were aneurysms and ectasias, and these were all located in the proximal thoracic aorta, so the upper part of the aorta near the heart. Specifically, there were 8 patients with aneurysms and 17 with ectasias, so once again, the enlargements that didn't meet the thresholds for aneurysms, but were still clinically monitored. Acute aortic syndromes were relatively rare. They occurred in 3 patients. 2 of those patients had Stanford type A dissections that required surgical repair, and then 1 had a Stanford type B intramural hematoma. And Stanford type A and type B are just classification systems based off of where those dissections were located in the aorta. Going to the next slide really quickly, we've included a CTA 3D reconstruction from one of those patients. This patient had multifocal FMD that involved their mesenteric, renal, and iliac arteries, and you can probably see it best by the beading in the iliac arteries towards the bottom, alongside a history of a Stanford type A dissection that needed surgical repair. And this case just visually highlights the extent of arterial involvement in FMD, as well as the potential for severe aortic complications. Going back to the previous slide, we found congenital anomalies in the structure of the aorta in a total of 9 patients, and this was most commonly a variant artery branching pattern known as an aberrant right subclavian artery, and notably, no patients had aortic stenotic lesions. We then went on to compare the characteristics of the patients with and without aortic involvement, and that comparison is seen in this table here. FMD is known to primarily affect females. 98% of our cohort was females, but we did have a higher percentage of male patients in the group with aortic involvement. 8% in that group were male compared to 1% in the group without aortic involvement. We also noted significantly higher rates of renal, mesenteric, and iliac vascular bed involvement in the patients with aortic pathology, and this group of patients also showed a higher prevalence of high blood pressure, non-aortic aneurysms, as well as a higher risk vascular phenotype. In terms of family history across the entire cohort, reported family history of aortic aneurysms was 13.8%, of aortic dissection was 3.9%, and then of FMD was 8.4%. And this suggests that there is some heritable component that underlies FMD, but these family history patterns were similar whether or not the patients had aortic involvement themselves. Lastly, towards the bottom of this table, 36% of 36 patients with aortic involvement. Out of the 36 patients with aortic involvement, 25% of them underwent genetic testing for established aortopathy genes. So these are things like Marfan's, Louis-Dietz, Ehlers-Danlos, and all of this testing returned negative. The absence of any identifiable one-gene variants in these known aortopathy genes really highlights that FMD-related aortic disease may involve unique and alternative genetic mechanisms. So, in summary, we found that 1 in 10 patients with multifocal FMD had changes in their aorta, and this most commonly presented as myodilation or aneurysms in the upper chest area. This reinforces the evolving understanding that FMD is a systemic arteriopathy and that the aorta, as a larger blood vessel, should not be overlooked. From a clinical perspective, our findings strongly support the current guidelines of complete imaging of the entire aorta. And in addition to imaging, good blood pressure control is one of the most important steps that patients can take to help prevent all of their arteries and reduce the risk of complications. Through imaging, early identification of even mild aortic changes allows for targeted surveillance and timely interventions that can be life-saving. And then looking ahead, we hope that larger longitudinal studies can help us better understand if and how these aortic changes progress over time, improve risk stratifications for patients, and uncover more about the potential genetic causes of this disease. Thank you so much.
Great job, Karen. I am going to turn it over to why don't we start with Dr. Ganesh and then Dr. Freilich for comments.
It's a great study. Congratulations, Karen and Heather. I enjoyed seeing some of that data. I thought there are a few points that come to mind as I'm looking through what you presented there. The first is that thoracic aortic aneurysms are thought to be more often heritable, genetically mediated through some of those rare variants. So it's very interesting that you did not find variants in the genes that were tested for. I think that's pretty notable. And some things that, I wonder about is hypertension is a risk factor for aortic aneurysm, aortic dissection. In this population, sort of examining what those hypertension patterns were in affected individuals would be really interesting. And I also wonder about kind of what is the baseline prevalence of these findings that we are finding because we're doing the head through pelvis imaging. And, what might be those numbers for people with and without hypertension is sort of one of the main interaction points. So the final point I might make is that even in thoracic aneurysm, when it's clearly familial, that there's a clear autosomal dominant pattern, our pickup rate for the currently known genes is less than 1/3. And so the majority of those cases, even when it's the grandmother, the son, the granddaughter all have the same manifestations and the same genetic kind of pattern in their family tree, that we most often don't find something on our testing. So I think your interpretation there sounds really good, that there's more we need to learn what is driving that, but it's very interesting and something that I think when I do the head through pelvis imaging, I include the chest, right? And many of us do. And a question might be, if we're looking for FMD, do we need to include the chest portion? Or I think our protocols are mostly set up to do that. But as we get more data, since those recommendations were made, I feel like we're seeing more consistent data. It'll be interesting to see increased numbers. Congratulations on that.
Thank you, Santi. Jim, additional comments?
Yeah, also congratulations. I think that this is a very important study, and I'm glad you had numbers. I would say two things. One, to echo what Dr. Ganesh said, I think it's really important that we do complete the protocol that is recommended and do thoracic imaging of the aorta as well as abdominal imaging of the aorta in these patients. I would like to see more referral for genetic testing. I'm certain that our current knowledge is incomplete, as Dr. Ganesh mentioned, that there's a lot of genetic arteriopathies out there that haven't been discovered yet, but I think it's clinically really important that all these patients get referred. So I have a very and lowering threshold all the time for referring patients for genetic arteriopathy testing. And when I find patients who do have aortic involvement, I will usually refer them, but particularly if they've had a dissection or an event or a family history that's suggestive. So I think this is important. I think it also suggests that we have to stay humble, not only in the number of arteriopathies out there that haven't been discovered, but also in our characterization of FMD. I mean, this is almost entirely an imaging-based diagnosis, and I suspect there's a lot of phenotypic and genetic heterogeneity that we are overlooking. And the only way to approach that is with the work of Dr. Ganesh and others in the gene discovery area. But in clinically, I think it's important to test for the genetic, to test for what is known, as you have. So I'd like to see that number go up, that percentage. But this is great work, and certainly begs a lot of important questions.
Karen, thank you very much. Congratulations. All right, we are now going to move to our third presentation. This is actually related to the second one, and this is a case study. This is Dr. Prianca Tawde. She is from Cornell. Her mentor is Nupur Narula, and her case is extensive type B intramural hematoma in a patient with FMD and bicuspid aortic valve.
Thank you for that introduction. Can you guys hear me? Great. As Dr. Gornik said, my name is Prianca. I'm currently a second-year resident at Weill Cornell. And here I am presenting a extensive type B intramural hematoma in a patient with fibromuscular dysplasia and a bicuspid aortic valve. Special thanks to Dr. Nupur Narula, who helped put this together and lead this project, and all the other authors on our case report, including Dr. Olin. So as we've been talking all day, a little bit of context. FMD, as you know, is a non-atherosclerotic, non-inflammatory vascular disease that can affect any artery with stenosis, beating, aneurysm, or dissection. Our patient also presented with an intramural hematoma, which is a specific pathology that affects the large blood vessel of the body, the aorta, and is distinct from an aortic dissection because there is no intimal tear or can't visualize it. And then I would also like to introduce a bicuspid aortic valve, which typically the aortic valve is tri-leaflet or with 3 leaflets. And some patients have a congenital disease, which causes the 2 of the cusps to fuse, leading to a bicuspid aortic valve. So our patient was a 48-year-old female with hypertension, diabetes, and hyperlipidemia, who presented to the ED or the emergency department with 1 week of progressive chest pain and headache. At this point, our differential was broad, including inflammatory vasculitis, hypertension, acute coronary syndrome, pulmonary embolism, or acute aortic syndrome. A little bit more of her past medical history. In speaking to her, she had poorly controlled hypertension on nifedipine and lisinopril for a couple years. She actually had presented to an ED at a different hospital about a week prior to this hospitalization with hypertension and back pain, but did not get imaging at that time. And then she denied any history of fevers, chills, weight loss, substance use, or family history of cardiovascular disease that she knew of. Other key data that she presented with, her vitals were abnormal with a blood pressure of 170/106. It was elevated. Her heart rate was 108 beats per minute. She was sitting on room air at 98%. And then her exam was most notable for her being uncomfortable, in distress, in pain, but otherwise unremarkable in terms of her cardio and pulmonary exam. And then I wanted to highlight some labs from her admission, which included a creatinine level of 0.6, which is within normal range, kind of reflecting her kidney function. And then her liver function tests, or AST and ALT, were both also within normal range. And then her high sensitivity troponin, which is a cardiac marker, was within normal range. And then, but her D-dimer, which can be elevated in multiple different pathologies, including pulmonary embolism or aortic pathologies, was elevated to 3,603. As she was presenting with chest pain, she got an EKG in the emergency department, and we were looking for ischemic changes or any findings here. And other than a fast rate, her EKG did not show any acute ischemic changes. And because of her hypertension, chest pain, back pain, and D-dimer, she got a CT of the chest, abdomen, pelvis to further evaluate. And on this imaging, we saw a 9mm eccentric thickening of the aorta. If you can see my cursor, oh, probably can't. It's right here. And essentially, it started from the left subclavian artery, so kind of closer to the left shoulder, going all the way down to the right common iliac artery, so all the way to the hip almost. And this was consistent with a type B intramural hematoma. On this imaging, she was also incidentally found to have a string of bead appearance of the bilateral mid to distal renal arteries, and this was concerning for fibromuscular dysplasia. As part of her workup, she also got an echocardiogram or an ultrasound of her heart, which showed a low normal left ventricular function, so LVEF of about 50%, where normal is 60. And here we've zoomed in on her aortic valve, showing that fusion between her right and left coronary cusp, confirming a bicuspid aortic valve. But notably, she did not have any significant aortic valve dysfunction, no regurgitation or stenosis, or ascending aortic dilation. So after being admitted to the cardiac ICU, the patient was started on intravenous esmolol and nicardipine, so anti-impulse therapy. CT surgery was consulted. They recommended a non-operative management with medication. Her chest pain improved and her blood pressure came under control, and she was transitioned to an oral antihypertensive regimen and was discharged with follow-up. At her follow-up 7 weeks after her hospitalization, she showed significant spontaneous progression of her intramural hematoma, looking at the image on the left, where you still see that was the admission CT compared to the image on the right, where the aortic wall looks a little more. So this patient showed us a couple key takeaways. One, FMD was instantly diagnosed during imaging for this acute aortic syndrome. It showed us the importance of head to pelvis imaging in FMD because it's a systemic vascular disease associated with aneurysm and dissection greater than 40%. And as Karen showed us, approximately 10% can have aortic involvement. This extent of type B intramural hematoma in FMD has only been reported once before to our knowledge. And then the contribution of the bicuspid aortic valve to intramural hematoma is uncertain in this case, especially with no valvular abnormalities or dilation of the ascending aorta. And then in terms of the intramural hematoma regression at 7 weeks, it does align with our understanding of spontaneous improvement in about 1/3 of patients. Our next steps for this patient include imaging of her cerebral vessels and then also genetic testing, as you guys highlighted on the last.
Terrific. Congratulations. And we actually came upon each other at the AC's. Karen and Prianca met at the ACC meeting, and we're comparing notes on, we had 3 cases, and this is one additional case with acute aortic syndrome with FMD. So I'm going to turn it over now to Drs. Kim and then Dr. Ganesh for commentary. Esther.
Yes, I actually had a patient with an acute aortic syndrome and FMD when I was at Cleveland Clinic. So it's really not uncommon, but I think if you see enough patients, you'll run into it. Great job with the presentation, great job with the management. A couple key things. Number one, for the patients out there who have FMD and who have a history of SCAD, not all chest pain symptoms mean heart attack. And so it's really important to go to the emergency department if you're having severe acute onset chest symptoms, because it doesn't mean that it's another SCAD and it's going to be medically managed again. It can be other things. And so I think this case really highlights the importance of a thorough workup. Just because somebody has a disease, you shouldn't assume the workup is already done. The other thing here that I wanted to highlight, when should we be sending patients with FMD to genetics? And the thing in my clinical practice that I go by is if the patient doesn't fit the sort of typical or the average severity for the FMD patient. So if I see a frank aortic aneurysm, an acute aortic syndrome, multiple aneurysms and dissections, which I feel are sort of out of the realm of my average FMD patient, I really start looking for other things. And perhaps it's very difficult to know. We'd be interested to find out what the genetics are, but maybe the aortic disease is related to the bicuspid aortic valve, because we know aneurysms run along with that disease process at a much higher frequency than with FMD. But great job.
Santhi, over to you.
Yeah, great. No, I agree with those points. And Priyanka, congrats on a nice case presentation. That was very well done. I guess, I echo what Esther, you were bringing up, that, bicuspid aortic valve is known as one of the more common rare diseases. It has a genetic basis. We don't have a genetic test for it. We recommend echo, for example, to look for the valve abnormality in first-degree family members. So I do wonder about just the concurrence of those. But also, as Esther mentioned, we have a lot of information about bicuspid valve and the ascending aorta, that it's not just turbulent blood flow from that abnormal valve, but that the aorta itself has abnormal architecture and is more prone to becoming enlarged or having problems within it. And so I agree, this is a situation where I would be thinking about testing. It's out of the norm. The severe hypertension caught my ear, though, as potentially the trigger, as we know that that's a risk factor. And so I'd be curious, in the longer term surveillance of this patient, the aortic surveillance, but also how's the hypertension management going? Because as you found renal artery FMD, you may have a more severe renovascular hypertension going on there that might need to be looked at. Thank you.
All right, well, thank you so much for that terrific case study. And now we're going to move on to our next presentation. We welcome Dr. Andrew Philipose, who's mentored by Kamal Gupta at the University of Kansas. And he's going to present to us on the natural history of carotid web in asymptomatic and symptomatic patients. This is something that may be somewhat new to some of the attendees, so we'll have some discussion after the abstract. Welcome.
Awesome. Thank you so much. Can you guys hear me okay? Perfect. So my name is Andrew Philipose. I'm a second-year internal medicine resident at the University of Kansas. And as mentioned before, my mentor is Dr. Kamal Gupta. So great thanks to him for getting me introduced into vascular medicine and then FMD. So the presentation is about natural history of carotid web in asymptomatic and symptomatic patients. So for a little bit of background, I just wanted to talk about the carotid artery in general. It's a vascular structure that starts from the aorta and supplies the brain. There's this portion called the carotid bulb that kind of sits just behind the mandible. And this is where the common carotid bifurcates into the internal and to the external carotid artery. The internal carotid artery feeds the brain, while the external carotid artery will course outside of the skull and feed most of the muscles and the skin of the face. In this image, which I took from Mayo Clinic, you can see the carotid bulb is circled here, and they highlight disease of the carotid artery. This is atherosclerotic disease, so a lot of plaque buildup. And basically all this is highlighting is disease of this region can lead to stroke. So some of this plaque buildup can embolize and cause stroke in different parts of the brain. So then this takes us to this question, what is a carotid web? So a carotid web is a a focal intimal protrusion into that carotid bulb that we had mentioned, and more increasingly recognized as a factor of embolic stroke. So here are a couple different imaging studies, everything from a CTA to an ultrasound that kind of points out this protrusion into the wall. And then we also have some surgical slides. You can see how this web is protruding into the vessel wall and can cause some turbulence and then some space for thrombus formation. So here on the next slide, we talk about how carotid webs have been implicated in ischemic strokes of unknown origins in patients that have few risk factors and who tend to be younger. Current studies focused on patients who suffered from stroke with few risk factors, and age is generally between 30 and 50. They tend to be female and they tend to be of African descent. However, no one has looked at asymptomatic patients. Again, all these patients have a history of stroke, and the demographics and the clinical characteristics are not well established in asymptomatic patients. The images below, I just wanted to highlight, this is a CTA of a carotid artery that has a web, and you can see as they let the contrast progress, some more contrast is kind of hanging out in that space behind the carotid web. So this is where we believe that there's some hemostasis and some clot formation, and under the right circumstances, this clot can embolize and lead to that stroke. So what we did in our study is we conducted a single center study to understand the demographics, clinical and imaging characteristics of the natural history of patients with both symptomatic and asymptomatic web. So we use this AI software Illuminate to comb through our electronic health record and identify patients that had carotid web identified either in any imaging studies or somewhere in their chart. And then we directly visualized all of the images, and we identified patients that had a true carotid web versus those that were kind of suspicious looking. All those that had a true carotid web were included in the study, and we categorized them as either symptomatic or asymptomatic. And symptomatic were those that were received the CT for CVA or for TIA, whereas those that were asymptomatic received the imaging study for other reasons. So those reasons can include trauma. So if they had like a vehicle trauma, or if they had a fall, aneurysm, headache, or if they were just getting reevaluation for FMD or for a known aneurysm. And if you look over on the right, you can see that the vast majority of our patients, about 55% of them, have a symptomatic carotid web. So they were being managed for CVA or TIA, whereas the remaining 45%-ish were more asymptomatic. And this is the results of our study. We identified 133 patients. I wanted to highlight that the mean age of our study is about 60 years old, which is significantly older than what was presented earlier, which is a range of 30 to 50. We did confirm that vast majority of patients are female. About 70% of our patients in our cohort were female. And then highlighting the race component, about 61% were actually white and not following that African descent model that had been presented a little bit earlier. And then looking into the comorbidities, we see that patients with carotid web tend to have higher rates of diabetes and hyperlipidemia. So comparing 31% versus 10% between our patients that have clinical stroke versus incidental, and then 70% to about 40% in patients with hyperlipidemia. And then fibromuscular dysplasia and migraines, interestingly enough, were more prevalent in the asymptomatic group. So it's unclear, based on this data, it seems like fibromuscular dysplasia and migraines do not predispose patients to a more symptomatic presentation of this carotid web. So in conclusion, our study confirms that most patients are female. The vast majority identified as white, and the mean age is, again, significantly older. So carotid web may actually have a broader demographic presentation than previously recognized. And then we also demonstrate a close relationship between ischemic stroke and carotid web just in the setting of traditional vascular risk factors. In a lot of patients that do not have some of these vascular risk factors, the rate of stroke may actually be a little bit lower than we expect. So the big takeaways, again, focusing on demographics, it may be broader than we previously expected. especially among those who are asymptomatic. Patients who are asymptomatic generally don't seem to be at greater risk of ischemic stroke. And then patients with FMD may not be, or FMD may not be an independent risk factor for symptomatic carotid web. So what patients need to know, carotid webs are implicated in strokes of unknown origin, and the presence of these webs may be a little bit more prevalent than previously reported, especially among those who are asymptomatic. However, they may not contribute to stroke as much as we had previously believed. So next steps for us, we have a manuscript that's in process, and then we're awaiting data from other universities. Dr. Parmar, who also worked on this project of Massachusetts General Hospital, has another data set of about 190 patients who we're looking very eagerly to see that data and to see that published pretty quickly. So that's my presentation. Thank you so much.
Wonderful. Congratulations, Dr. Philipose. For this one, we're going to have Dr. Olin comment, and then I'll comment as well. Jeff.
Yeah, that was great. I've had an interest in carotid webs. There was a review paper in Stroke by 6 experts on extracranial carotid disease, and 3 of the images were of carotid webs that they didn't even mention. And Dr. Kavian and I wrote a letter to the editor that this is a major thing to know about, because the thought was it's a major cause of stroke. What I still don't understand is if you see a carotid web, and I do not believe a carotid web is fibromuscular dysplasia, as some of the earlier literature suggested. But if you see a carotid web, there are neurologists or neurointerventionalists who believe it should be taken care of no matter what, whether you have symptoms or not, because the stroke rate is very high. There are others, such as your presentation, and I'm really not sure if these patients are at a markedly increased risk, and would you do anything more, such as aspirin and clopidogrel instead of aspirin alone, or should they go and have an intervention, either surgical or endovascular? I don't think that question has been answered. Heather?
Yeah, I'm also really interested in these, and I feel like now that our CT imaging is getting so much better with these thin slices, we're seeing this more. And I will say this is something we've seen in some of our patients with FMD and SCAD. They have the classic string of beads, and then they might have a short web. I think there's a lot to be known about what to do with them. As Jeff said, I think the main point is if someone has one of these and they're having TIA or stroke, the literature really suggests that those are not people we're going to put on another blood thinner. Those are the people who need it to be fixed. But really a need for more literature here. So Andrew, really encourage you to get this manuscript under peer review so it can get contributed to the literature. All right, thank you very much. We now have our last presenter, who's a little more senior but still a fresh face to the FMD Society of America. I'd like to welcome Dr. Lori Tam, who's a cardiologist in the Providence Health System, which is actually one of the newest sites for the North American Registry for FMD, with Dr. Alejandro Perez as the principal investigator. Dr. Tam collaborates with Perez and is an investigator. She's the local principal investigator for the iSCAD registry. So she is going to give this presentation on behalf of the iSCAD registry, Sex Differences in SCAD. Welcome, Dr. Tam.
Hello, thank you for having me. I am Lori Tam. I'm a cardiologist and a medical director of the Providence Women's Heart Institute here in Portland, Oregon. I did my training at Brigham and Women's Hospital in internal medicine and cardiology fellowship at Johns Hopkins. I'm grateful to be here today to share this with you. So I'm going to go ahead and get started right here. Are you able to make
Not
sure
yet.
my
If you could
slides
reshare.
are on? Yep. Okay.
Got them.
There we go. Is that right? Okay.
Actually, your slides are still, there we go. Good.
Okay. All right. So I'm going to go ahead and share with you sex differences from the International SCAD Registry, a report of the iSCAD Registry. And as Dr. Kim had alluded to earlier, spontaneous coronary dissection is increasingly recognized as an important cause of acute coronary syndrome or heart attacks, particularly in younger women. SCAD is a non-iatrogenic, meaning it's not caused by a doctor, dissection of the epicardial coronary arteries, which feed the heart, not due to plaque or atherosclerosis, and not due to trauma. The resulting intramural hematoma or dentumal disruption between the layers of the walls of the coronary artery results in coronary artery obstruction. So just a little bit of background, 90%, nearly 90% of SCAD cases occur in females. The majority of these are middle-aged women. SCAD accounts for up to about 40% of acute coronary syndrome or heart attacks in women under the age of 50. The prevalence of fibromuscular dysplasia in patients with SCAD ranges anywhere from 25% up to 86%, depending on the studies. Many studies quoting numbers closer to 50% at least. Given the low incidence of SCAD in males, however, there is limited data regarding the characteristics of males who develop SCAD. So the objective of our study was really the objectives is to examine sex differences in spontaneous coronary artery dissection by looking at baseline demographics, presenting characteristics, precipitating factors, angiographic findings, management strategy, cardiovascular outcomes, and discharge medications. This was a multi-center perspective observational study. We utilized the sex and gender equity and research guidelines for the reporting of sex. Male and female sex was self-reported by patients based on sex at birth. Inclusion criteria included patients that were older than 18 years old of a diagnosis of SCAD based on catheter-based coronary angiography, or a history of SCAD based on that. Patients that had a coronary artery dissection due to atherosclerosis or as a result of iatrogenic injury were excluded. So our SCAD registry involves a number of sites throughout the United States. Over 20 sites are enrolling currently. And in terms of study design, the outcome measures included descriptive data of participant demographics, historical, clinical characteristic, and treatment data. Clinical outcomes included looking at in-hospital outcomes, including major adverse cardiovascular events, the composite of myocardial infarction or heart attack, stroke or heart failure. We also assessed recurrent myocardial infarction or heart attack, hospitalization, heart failure, length of stay, arrhythmia, all-cause mortality, and discharge medications in males and females. We also assessed psychosocial outcomes, which was prospectively collected using a questionnaire validated for evaluation of mental health. So in terms of our baseline characteristics, they were actually quite similar between males and females. The average age was right around age 50, and there were similar findings in terms of history of diabetes, high blood pressure, coronary atherosclerosis, smoking, and similar numbers of patients with extracoronary vascular abnormalities. And in terms of our results, we found that there were certain triggers that were different. We found that in female patients, they were more commonly triggered by emotional stress. In male patients, their SCAD event was more often triggered by physical stress, whether it be isometric exertion or aerobic exertion. In terms of clinical history, we found that autoimmune conditions, systemic inflammatory disorders, fibromuscular dysplasia, migraine were more commonly reported in female patients, and recreational drug use was more commonly reported in male patients. In terms of SCAD presentation, chest discomfort was the most common presenting symptom among both male and female patients. However, females more often reported presenting symptoms of non-chest discomfort, such as neck, jaw, shoulder, arm, back pain, discomfort, shortness of breath, nausea, and vomiting. There was no sex differences in the clinical presentation of SCAD in terms of the type of heart attack, whether it was an ST elevation or non-ST elevation heart attack, no difference in cardiogenic shock, cardiac arrest, or ventricular rhythm abnormalities. In terms of angiographic characteristics, we knew that in SCAD presentation, we found that angiographic outcomes, there was no significant difference in in-hospital myocardial infarction, multi-vessel involvement, heart attack related to different types of SCAD, and no other than there was a higher incidence of type 1 SCAD, which is more of a dissection appearance in male patients, but no difference in terms of in-hospital heart failure or new rhythm abnormalities. And in terms of length of stay, we found that there was a significant difference as the median length of stay was longer for female patients. This persisted even after pregnancy-related SCAD patients were excluded. The mean length of stay for males was 3 days, mean length of stay for female patients was 4 days. And at discharge, we found that males were more likely to be prescribed statin medications and more likely to be prescribed dual antiplatelet therapy medications on discharge compared to their female counterparts. So in conclusion, with this, this is a large SCAD population, and in this population, we found that females reported higher rates of emotional stress preceding SCAD, while males more often reported physical stress and exertion as a trigger. Females had higher rates of fibromuscular dysplasia, autoimmune conditions, systemic inflammatory disorders, and migraines. Men had a higher prevalence of recreational drug use. And although chest pain was the most common presenting symptom overall, symptoms in male patients, female patients were actually more likely to include non-chest pain, non-chest discomfort symptoms. And although the age and baseline characteristics really did not differ between the males and female patients, we found that, and that clinical presentation, clinical coronary territory of involvement, management strategy, and in-hospital outcomes were similar between the sexes. The hospital length of stay was longer for women. For female patients, excuse me. The length of stay in females were longer even after excluding pregnancy-related SCAD, and there was no significant difference in terms of territory of involvement. We also found that males were more likely to be discharged on dual antiplatelet therapy and statins, despite no difference in baseline hyperlipidemia, cholesterol levels, and no difference in the history of atherosclerosis or non-coronary atherosclerosis found between the patient population. So in terms of implications for patients, we know that there is, this is the first study to report a longer length of stay for female patients compared to male patients. First study to report higher rates of antiplatelet and statin therapy on discharge in men. In male patients, higher prevalence of extravascular screening more than in the many other studies in SCAD. We found that female patients with SCAD had higher rates of fibromuscular dysplasia than male patients. The study reflects the findings of contemporary real-life medical practice and the treatment of SCAD patients in the U.S. So in terms of next steps, we understand that there is a significant overlap between SCAD and FMD. Both SCAD and FMD predominantly affect middle-aged women. Extracoronary vascular abnormalities are frequently seen in both, especially in the terms of aneurysm, non-coronary artery dissections, tortuosity, both in patients with SCAD and FMD. Given the high prevalence of FMD in patients with SCAD, it's possible that FMD is potentially one of the underlying systemic arterial abnormalities in SCAD. Clinicians really need to understand the importance of screening for SCAD in patients presenting with SCAD. For FMD in patients with SCAD. And this usually includes head to pelvis CT imaging for a full assessment of their vascular abnormalities. And further research really needs to be done regarding the genetics of FMD, where that overlap might be, and also the influence of sex hormones on susceptibility and triggers for fibromuscular dysplasia and spontaneous coronary artery dissection. So thank you for allowing me to share today.
Terrific. Thank you, Dr. Tam. I'm going to turn this over to Drs. Ganesh and Freilich for comments. Santi, let's start with you.
Yeah, that's terrific. Really nice work, Lori and Esther and team. I think, I as background, my own collaborations are with the Canadian SCAD Registry, CanSCAD. They had approached us many years ago for collaboration there, and we had an analysis in 2022 of sex differences. And it's always nice when we see between registries that their findings are concordant. And this kind of association of what the trigger may be for SCAD according to sex, that definitely aligns, as does the in-hospital, outcomes that there seems to be a lot of alignment there between the two. So I'm pleased to see that, just as far as understanding the data and learning more about SCAD. And I think, I'll be talking next, so I'll have a little bit more to say about the relationships between FMD and SCAD, and maybe I'll leave it there.
Jim.
So congratulations, Dr. Tam. This is a great study. Really important, and congratulations to the whole iSCAD team. I know a lot of work goes into something like this, and now that you have these robust numbers, you can actually do something like a gender discussion. And I think a couple things are worth pointing out just quickly. One, I suspect that what we're seeing is mostly non-FMD related SCAD in men and mostly FMD related SCAD in women. And so the numbers actually make sense. There's probably non-FMD related SCAD in women, but it's probably commensurate with the numbers seen in men, would be my guess. A lot of what you're seeing, as you know, as a cardiologist, we've seen in non-SCAD, non-FMD related MI, right? The difference in the disparity in treatment, we've seen that before between the sexes, and the differences in presentation. And I just want to, again, point out the inherent sexism in our system when we refer to the way women present with MI as atypical, which is clear sexism because it means the typical was defined by how men present. And so this reinforces, again, I think, something that now we know is happening in SCAD as well as non-SCAD MI, and that is different symptomatic presentation. So your research reminds us to be suspicious for MI in women who present with non-chest pain, and to be suspicious for non-extracardiac manifestations or causes in women who present with SCAD. And I think it'll be great to see more work done in this area. So very interesting.
All right, well, Dr. Tam, thank you for your presentation. I'd like to thank all of the presenters for this session. I think this was a success. I think we'll do it again at a future FMDSA meeting. Just great to have some new faces and perspectives. Also want to thank our panelists. I do want to point the attendees on the online platform. There's 3 additional research presentations. We just didn't have enough time to do all of them live. So there are 3 other presentations for you to view. And Pam, shall we take a 5-minute break and return at 2:10?
I think that sounds like a great idea. I'm ready for a short break.
See everyone back at 2:10.